Hello, this is Professor Hale. I'll be covering Chapter 49 in your medical surgical book, Nursing Care of Patients with Cerebrovascular Disorders. Learning outcomes for this chapter includes describe causes, risk factors, pathophysiology, identify emergency interventions, plan therapeutic measures for transient ischemic attack, ischemic stroke, and hemorrhagic stroke. In addition, learning outcomes for this chapter will be to identify outcomes that can be expected for a stroke victim, plan nursing care for a patient with cerebral vascular disorders. So starting off with a transient ischemic attack, which is also known as a mini stroke or TIA, it is a temporary blockage of blood to the brain that causes a transient, brief neurological impairment. The episode typically lasts minutes to hours, and the patient recovers completely. Risk factors, causes, and symptoms of a TIA are identical to those of a stroke. So if the blockage that causes a TIA does not reverse in that area of the brain, it is permanently damaged, and the event is a stroke. About 15% of strokes of TIA are preceded by a TIA. This is according to American Heart Association and American Stroke Association. And urgent evaluation of a TIA is essential to decrease the risk of stroke. So treatment of a TIA is focused on preventing a full-blown stroke. The causes of a TIA may be discovered with diagnostic tests, which then can guide treatment. However, there may be no clear etiology of a TIA. Treatment, therefore, is most likely centered on minimizing the patient's risk factors for a stroke. So here we are, stroke. Strokes are known as cerebral vascular accidents, which is CVA, or brain attacks, which involves a disruption of the cerebral flow secondary to ischemia, hemorrhage, brain attack, or embolism. Strokes can be classified into two main categories, which are ischemic strokes, which are strokes caused by a blockage of any artery, hemorrhagic stroke, which are strokes caused by bleeding. Ischemic strokes occurs when the blood vessel that supplies the brain becomes blocked or clogged and impairs blood flow to the part of the brain. The brain cells and tissues begin to die within minutes from lack of oxygen and nutrients. Ischemic strokes are further divided into two groups, which is thrombotic strokes. These are caused by a blood clot that develops in the blood vessels inside the brain. And then we have the embolic stroke, which are caused by a blood clot or plaque debris that develops elsewhere in the body and then travels to one of the blood vessels in the brain through the bloodstream. Thrombotic strokes are strokes usually caused by a blood clot that develops in the arteries supplying blood to the brain. This type of stroke is usually seen in older persons, especially those with high cholesterol, atherosclerosis, which is a buildup of fat and lipids inside the walls of the blood vessels, and also diabetes. Sometimes symptoms of a thrombotic stroke can occur suddenly and often during sleep or in early morning. Or at other times. It may occur gradually or over a period of hours or 7 days. Embolic strokes are usually caused by a blood clot that forms elsewhere in the body, which is embolus, and it travels through the bloodstream to the brain. Embolic strokes often result from heart disease or heart surgery that occur rapidly and without any warning signs. Moving on to the hemorrhagic type strokes, they occur in the blood vessel that supplies the brain, and it ruptures and bleeds. So when the artery bleeds into the brain cells and tissues do not get oxygen or nutrients. In addition, the pressure builds up in the surrounding tissues, and irritation and swelling occur, which can lead to further brain damage. Hemorrhagic strokes are divided into two main categories, including the following of intracerebral hemorrhage, which is bleeding from the vessels within the brain, and then subarachnoid hemorrhage, which is bleeding in the subarachnoid space, which is the space between the brain and the membranes that cover the brain. So intracerebral hemorrhage is usually caused by high blood pressure. Bleeding occurs suddenly and rapidly. So there are usually no warning signs, and bleeding can be severe enough to cause a coma or a death. Subarachnoid hemorrhage, it results when bleeding occurs between the brain and the membrane that covers the brain, which is the meninges, in a subarachnoid space. So this type of hemorrhage is often due to an aneurysm or arteriovenous malformation, and it's also caused by trauma. So an aneurysm is usually weakened and ballooned of an artery wall, and it has a risk for rupturing. Aneurysms may be congenital, can be presented at birth, or may develop later in life due to factors such as high blood pressure or atherosclerosis. Risk factors for stroke could be modifiable, which are risk factors that you can reduce the risk factors by medication, diet, or lifestyle changes, and then non-modifiable, where you cannot change the risk factors because due to age, gender, hereditary, or if you had a prior stroke or heart attack. So you cannot change or decrease the risk because it's already there. You already have those risk factors. Modifiable risk factors are those that could be, you could reduce your risk factors reduced by diet, medication, such as hypertension, smoking cessation, warfarin or anticoagulants for atrial fibrillation, or some medications, carotid stenosis, or any other of those listed there under the modifiable. Specifically for women, the factors that increase the risk for stroke are pregnancy, oral contraceptives, hormone replacement therapy, high triglycerides, history of migraines, or thick waist. So what really increases your risk factor for stroke is if you smoke and if you're on oral contraceptives. It doesn't matter what age, it really increases your risk factor for stroke. This is a score risk card that the National Stroke Association came up with, and this is for the patients and family members that should be taught to recognize signs and symptoms and know how to activate emergency medical services, the EMS, if these signs occur. There is evidence that if treatment begins within 1 hour of onset symptoms of the stroke, permanent loss of function can be avoided or minimized. So, time is brain. So here are the warning signs of a stroke. Some people they're gonna have sudden numbness or weakness in one side of the body, one extremity or the other, sudden confusion, sudden visual changes, trouble walking, dizziness, and a severe headache. Most people describe that headache as the worst headache of their life. Here is an acronym which states for face, arms, speech, and time, which can be used to teach emergency triage nurses, first responders, non-licensed personnel, and community members to recognize the stroke symptoms and respond quickly. This is extremely important to preserve brain cells, so access to the EMS, if of a particular importance, is crucial. EMS can also focus on delivering a suspected stroke patient to a stroke center for rapid assessment and care. So as I work in the ER, the EMS actually will call us and give us heads up, the doctor, and let them know what their stroke score is, what they are as far as the FAST or deficits. Already, they probably will already have them on IVs, cardiac monitoring. So as soon as we are notified by the EMS and while they're en route to the ER, we actually call a code stroke. So the radiology, the CAT scan tech is made aware, so they get the CAT scan up and running, ready for that patient when they arrive to get them straight to the CAT scan, because that is the most important thing to determine if the stroke is the type of stroke, whether it's ischemic or whether it's hemorrhagic, because it makes a big difference on the treatment between the two. Acute signs and symptoms of stroke it depends on the area of the brain that's infected. One-sided weakness, either the left or right side, paralysis, dysphagia, sensory loss, mental status changes, and visual disturbance and speech disturbances. Usually, manifestations may vary based on the location of the brain that is deprived of oxygenated blood. So where the stroke occurred in the brain will determine the location of weakness. So injury to the left side of the brain, which controls language and speaking, can result in right side weakness. So if there's left-sided weakness, results from the injury to the right side of the brain, which controls the nonverbal communication and certain behaviors. Like in general, the left hemisphere, or the side of the brain that is responsible for language and speech, and because of this, has been called the dominant hemisphere, which is the left. The right hemisphere plays a large part of interpreting visual information and spatial processing. So keep that in mind. So we're going to go into a little bit more detail of the left cerebral hemisphere manifestations: expressive and receptive aphasia, agnosia, which is unable to recognize familiar objects, alexia, which is a reading difficulty, agraphia, which is writing difficulty, right extremity hemiplegia, which is paralysis, and hemiparesis, which is weakness. So visual changes like hemianopsia is a loss of visual field in one or both eyes. So those are terms that are good to know. In the right cerebral hemisphere, the manifestations are altered perception of deficits, unilateral neglect syndrome, which is they're unaware of if the left side is if left arm is affected, then that person is going to ignore. They cannot see, feel, or move that affected side. So the client is unaware of its existence. Loss of depth perception, poor impulse control and judgment, hemiplegia and hypophoria, and visual changes. Usually one-sided weakness, so it depends on what part of the brain. So one-sided weakness is called hemiparesis. It is weakness or the inability to move one side of the body, so it's making it hard to perform everyday activities like eating or dressing. One-sided weakness in your arms, hands, face, chest, or legs or feet can cause loss of balance, difficulty walking, impaired ability to grab objects, decrease in movement precision, muscle fatigue, and lack of coordination. The visual disturbances, most strokes affect one side of the brain, so if the right occipital lobe is injured, the left field of vision in each eye may be affected. A stroke that affects the left occipital lobe may disturb the right field of vision in each eye. Rarely both sides of the brain are affected, but this can result in blindness as well. And here is what the clients will see. And there's a list where you have the normal vision. So this is a good field to look at. It kind of gives you an understanding of their deficits and how they view things. So diagnostic procedures and tests would be a CAT scan of the head. It's the initial diagnostic test that should be performed within 25 minutes from the time the client arrival to the emergency department. This will assist in determine of the type of stroke, which is ischemic versus hemorrhagic, and whether the client is a good candidate for thrombolytic therapy. A magnetic resonance imaging, which is an MRI, which can be used to identify edema, ischemia, and necrosis of the brain. Also a magnetic resonance angiography, or a cerebral angiography, and are used to identify the presence of a cerebral hemorrhage, abnormal vessel structures or AV malformation, aneurysms, vessel ruptures, and regional perfusion of the blood flow in the carotid arteries, so help detect that. And also, what's not listed here is a lumbar puncture. It is used to check the presence of blood in the cerebral spinal fluid. It's a positive finding. It's consistent with cerebral hemorrhage or ruptured aneurysm. Dysphagia screening is the speech-language pathologist may perform a swallowing study. So the client swallows a barium substrate, and a radiograph is taken of the peristaltic activity of the esophagus. And also a Glasgow coma scale, and it's used when the client has a decreased level of consciousness or orientation. So the risk for increased intracranial pressure exists related to the swelling of the brain that can occur secondary to the ischemic insult. So the Glasgow coma scale is actually really important to initiate for that assessment when assessing with somebody with a hemorrhagic stroke. Effective treatment of stroke can prevent long-term disability, and it can save lives. So The specific treatments recommended depend on whether a stroke is caused by a blood clot, blocking the flow of the blood to the brain, which is ischemic stroke, or bleeding in or around the brain, which is a hemorrhagic stroke. Treatment usually involves taking one or more different medications, although some people also may need surgery. So, blood pressure control is vital for a stroke patient because of the lack of perfusion to the certain areas of the brain. The body's response is to increase the systolic blood pressure to force the blood to the affected areas. So if the patient will receive TPA or alteplase, which is the thrombolytic therapy, the blood pressure must be maintained below 185/110 to reduce the risk of bleeding. This is often done through the use of beta blockers, labetalol, or calcium channel blockers because of their fast-acting effects and ability to be given via IV. Usually those blood pressures are given IV because of they need to have immediate effectiveness. And also there's seizure prevention as well. Thrombolytic therapy, it is a medication that is called like a clot buster. This is called thrombolysis. So ischemic strokes can often be treated using injections of medication, which is called alteplase, or TPA, which dissolves blood clots and restores blood flow to the brain. So this use of clot-busting medication is known as thrombolysis. So alteplase is most effective if started as soon as possible after a stroke occurs, and certainly within 4.5 hours. It's not generally recommended if more than 4.5 hours have passed, as it's not clear how beneficial it is when used after this time. So before alteplase can be used, it's important that the brain scan is done to confirm a diagnosis of an ischemic stroke. And this is because the medication can make the bleeding that occurs in a hemorrhagic stroke much worse. Here is a video of how the TPA alteplase acts on the blood clot. As you can see, it's a narrowing of the artery there. The blood flow is going, and then when you see this plaque buildup or the clot, it's obstructing any blood flow to the brain, which can cause ischemic, cause dead tissue. And it's a cool medication. It really works pretty fast. So this is where time lost is brain lost, and that's what they mean by that. Here are medications, pharmacological therapy of ischemic stroke. So common medications used for a CVA are pretty much alteplase, which directly diverts plasminogen and plasmin, which degrades clot-bound fibrin. It's contraindicated in people who had active internal bleeding, history of CVA, cerebrovascular accident within 3 months, or history of intracranial or intraspinal injury or trauma to the recent stroke within 3 months, top period of time. It's contraindicated when clients have current use of anticoagulants, or if their coags are off, like the INR, if it's less than 1.7, or the prothrombin time less than 15. Or if they had heparin within 48 hours period of time. So they may not be good candidates for this medication if any of those occur. So this is what you need to focus on. What will prevent somebody of having this medication? So what factors that need to play in for them to qualify to have this therapy, and what labs to obtain and to monitor if and result prior to this administration. So that's something that's really important to know. Nursing implications, obviously I can't stress it enough. It must be administered within 3 to 4.5 hours, no later than 4.5 hours of symptom onset. So that's why it's important to know when they're last known well. That's a really important question to ask your patients. Monitor for bleeding, because obviously it's going to thin your blood. And frequent neuro checks as well. Here are other medications that are used as well. So for intra-professional care and post-emergent interventions, treat the cause of the stroke, which will be the thrombolytic therapy or medication or any procedures to stabilize them. And then there will be physical, occupational, and therapy consulted. medications to control their either blood pressure, cholesterol, or their clotting factors. So they'll probably be on either warfarin or aspirin for the remaining of their lives, and maintaining a patent airway. So for surgical interventions, we have the carotid endarterectomy, balloon angioplasty with stent, and thrombectomy. The carotid endarterectomy is performed to open the artery by removing atherosclerotic plaque. This procedure is performed when the carotid artery is blocked or when the client is experiencing a TIAs. So after the procedure, you want to monitor for increased headache, neck swelling, and hoarseness of the throat. The balloon angioplasty with a stent, it involves inserting a catheter in the femoral artery and placing by placing a distal embolic protection device to catch the blood clots. So during this procedure, while the stent is being placed in the carotid artery to open the blockage, it is less invasive, blood loss is decreased, and length of hospitalization is shorter. Post-operative care is the same as the carotid endarterectomy. For stroke prevention, hypertension, diabetes, smoking, and other related disorders can increase the client's risk for stroke. Early treatment of hypertension, maintenance of blood glucose within the expected range, and refraining from smoking will decrease these factors. Maintaining a healthy weight and getting regular exercise can also decrease a risk of stroke. So the long-term effects of stroke, which can vary from person to person, depending on the stroke severity and the area of the brain affected, may include cognitive symptoms like memory problems and trouble speaking, like aphasia, physical symptoms such as weakness, paralysis, and difficulty swallowing. So it could be dysphagia, difficulty swallowing, motor function, impaired sensation. Actually, the unilateral neglect, where the person, whatever side is affected of the extremity, they don't know that it's there. They don't, they can't feel it, they can't see it, it's completely like out of their mind. They just don't know they have that there. So that's what unilateral neglect means. Emotional symptoms like depression, impulsivity, which is pseudobulbar effect as well, can have like a sudden, uncontrollable, inappropriate laughing or crying, and heavy fatigue and trouble sleeping, to name. All right, moving on to discussing hemorrhagic strokes, which break it down to cerebral aneurysm and a subarachnoid hemorrhage. So a brain aneurysm is also known as a cerebral aneurysm or intracranial aneurysm. It is a bulge or a ballooning in the blood vessel in the brain. And aneurysm often looks like a berry hanging on a stem, so I'll give you that little visual. Experts think that brain aneurysms form and grow because of the blood flow through the blood vessel, and it puts pressure on a weak area of the blood vessel wall. This can increase the size of the brain aneurysm. So therefore, if the brain aneurysm leaks or ruptures, it causes bleeding in the brain, and this is known as a hemorrhagic stroke. Most often, a ruptured brain aneurysm occurs in the space between the brain and the thin tissues covering the brain. So this type of hemorrhagic stroke is called a subarachnoid hemorrhage. So the causes of brain aneurysms are by the thinning of the artery walls. Aneurysms often form at the forks or branches in the arteries because of those areas of the vessels are weaker. Although aneurysms can appear anywhere in the brain, they're most common in the arteries at the base of the brain. Risk factors include several factors that can contribute to the weakness in the artery wall. These factors may increase the risk of a brain aneurysm or aneurysm rupture. Some of these risk factors develop over time, but some conditions present at birth and may increase the risk of developing a brain aneurysm. Such risk factors include older age. Brain aneurysms can occur at any age. However, they're more common in adults between ages 30 and 60. Being female, brain aneurysms are more common in women than in men. Cigarette smoking. Smoking is a risk factor for brain aneurysms to form and brain aneurysms to rupture. High blood pressure. This condition can weaken the arteries. Aneurysms are more likely to form and rupture in the weakened areas, arteries. Drug use, or particular using of cocaine. Drug use raises blood pressure. If illicit drugs are used intravenously, it can lead to an infection, and an infection can cause a myocardic aneurysm. Heavy alcohol use, this can also increase blood pressure. So there's a multitude of risk factors that can contribute to this. Risk factors for a ruptured aneurysm is actually having a large aneurysm, having aneurysms in certain locations, smoking cigarettes, and having untreated blood pressure. So here are the signs and symptoms and manifestations that a client will have with a cerebral aneurysm or a subarachnoid hemorrhage. Most people will say that they have the worst headache of their life and believe them, and they need medical treatment right away. So other symptoms include photophobia, sensitivity to light, vomiting, disorientation, increased intracranial pressure, changes in the level of consciousness, seizures, nuchal rigidity, pupil changes, and motor dysfunction. Diagnostic tests include CAT scan of the head, which is a non-contrast computed tomography, and it's an initial diagnostic test that would perform within like 25 minutes from the time of patient's arrival to the ER department. This will assist and determine the type of stroke, whether it's ischemic versus hemorrhagic, and whether the client is a candidate for thrombolytic therapy. But we're talking about hemorrhage right now, so we're more focusing on that. Magnetic resonance imaging, which is an MRI, it can be used to identify edema, ischemia, or necrosis. Magnetic resonance angiography or cerebral angiography are used to identify presence of the cerebral hemorrhage. Abnormal vessel structures, which is AV malformation, aneurysms, also will detect vessel ruptures and regional perfusion of the blood flow in the carotid arteries and brain. A lumbar puncture is used to check the presence of blood in the cerebral spinal fluid. A positive finding is consistent with cerebral hemorrhage or ruptured aneurysm. So the cerebral spinal fluid is tested for xanthochromia, which is a yellowish appearance, and is a good indicator of a subarachnoid hemorrhage. Therapeutic interventions include a craniotomy, which is performed to create an opening in the skull to reach the aneurysm in the brain. The neurosurgeon places a small metal clip on the neck of the opening of the aneurysm, and this is to obstruct blood flow. And then non-surgical is monitoring and ensuring that the blood pressure is in control. So this is where you want to make sure the blood pressure remains at 120/80 in such patients. So here's another procedure that can be done. It's called ventricular peritoneal shunting. It is a surgery to treat excess cerebral spinal fluid in the ventricles of the brain. So the procedure is done as follows. Usually an area of the hair on the head is shaved, and it may be behind the ear or on top of the back of the head. The surgeon makes the skin incision behind the ear. Another surgical cut is made in the belly. A small hole is drilled in the skull, and on the end of the catheter is passed into the ventricle of the brain. This can be done with or without a computer as a guide. It can also be done with an endoscope that allows the surgeon to see inside the ventricle. A second catheter is then placed under the skin behind the ear. It is sent down to the neck and chest, and usually into the belly area. Sometimes it stops at the chest area. In the belly, the catheter is often placed using an endoscope. The doctor may also make a few more small cuts, for instance, in the neck or ear or near the collarbone to help pass the catheter under the skin. A valve is placed underneath the skin, usually behind the ear, and the valve is connected to both catheters. So when extra pressure builds up around the brain, the valve opens and excess fluid drains through the catheter into the belly or chest area. This helps lower intracranial pressure, and a reservoir on the valve allows for priming, pumping of the valve, and for collecting the cerebral spinal fluid if needed. And then the patient's taken to recovery area and moved into a hospital room for recovery. So when a brain aneurysm ruptures, the bleeding usually lasts only a few seconds. However, the blood can cause direct damage to the surrounding cells and can kill brain cells. It also increases pressure inside the skull. So if pressure becomes too high, it may disrupt blood and oxygen supply to the brain. Loss of consciousness or even death may occur. Complications that can develop after the rupture of the aneurysm include rebleeding. An aneurysm that has ruptured or has leaked is at risk of bleeding again. Rebleeding can cause further damage to the brain cells. Narrowed blood vessels in the brain. So after the brain aneurysm ruptures, blood vessels in the brain may contract, and narrow. So this is also known as a vasospasm. Vasospasm can cause an ischemic stroke in which there is limited blood flow to the brain cells. This may cause additional cell damage and loss. It can be a buildup of fluid within the brain known as hydrocephalus. So most common in a ruptured brain aneurysm occurs in the space between the brain and the thin tissues covering the brain. So the blood can block the movement of the fluid that surrounds the brain and spinal cord. As a result, an excess of fluid puts pressure on the brain and can cause damage to the tissues. And then a change in sodium level. Bleeding in the brain can disrupt the balance in sodium of the blood. So this may occur from damage to the hypothalamus and an area near the base of the brain. So a drop in the blood serum levels can lead to swelling of the brain cells and permanent damage. For nursing management, after a stroke is complete, management focuses on prompt initiation of rehabilitation for any deficits. During the acute phase of a neurological flow sheet, which is maintained to provide data about the following important measures of the patient's clinical status, which includes, monitoring, assessing the change in level of consciousness or responsiveness, presence or absence of voluntary or involuntary movements of the extremities, stiffness or flaccidity of the neck, plasticity, eye opening, comparative size of pupils, and pupillary reaction to lights, color of the face, extremities, temperature and moisture of the skin, their ability to speak, presence of bleeding, and maintenance of blood pressure. So during the post-acute phase, you want to assess the following functions, which is the mental status, memory, attention span, perception, orientation, affect, their speech and language. Sensation and perception, usually the patient has decreased awareness of pain and temperature. Also assess their motor control, which are assess their upper and lower extremity movement, swallowing abilities, nutritional and hydration status, skin integrity, their activity and tolerance, and bowel and bladder function. And then continue to focus on your nursing assessment on impairment and function of the patient's daily activities. So for prevention is to, sometimes it can't be prevented in some cases, but certainly quitting smoking helps, blood pressure management, limiting alcohol intake or illicit drugs, such as cocaine, because that can increase your blood pressure. So these are the certain things that can actually limit or reduce the risk of brain aneurysms. So for summary of the stroke of all the either hemorrhagic or ischemic, the takeaway is with the signs and symptoms, dizziness, syncope, visual disturbances, irritability, restlessness, confusion, decreased level of consciousness. There's going to be unequal pupils, paresthesis, motor weakness, paralysis, seizures, or difficulty swallowing or understanding language and speak. So those are the signs and symptoms you need to identify. Diagnostic test, which is computed tomography scan, magnetic resonance imaging, which is MRI, EKGs, carotid Doppler, echocardiogram, cerebral angiogram, and laboratory, which is international normalized ratio, prothymin time, metabolic panel, glucose, complete blood count, partial thromboplastin time, which is like the PTT, serum pregnancy, if appropriate, if they're within age, and oxygen saturation that you need to monitor. Therapeutic measures is oxygen for peripheral oxygen saturation, which is less than 92, antiplatelet, anticoagulant, and thrombolytic medications. Understand what they are, the indications, understand the classifications, pretty much the contraindications in each of the, especially thrombolytic medication, know that, and the lab values to monitor with that type of medication, with the thrombolytic therapy. Knee-high anti-embolism stockings, I didn't really go over that, but those are really good for nurse to apply for patients who had stroke or because they're not moving around as much. So when they're not at baseline and not moving anything, they're more high risk for blood clots. So they may be prescribed or, in their plan of care, they may be implemented. Complications, know the complications and how the stroke evolves, causing more deficits with aspiration pneumonia. Understand that they're higher risk for skin breakdown, urinary tract infections, and malnutrition. And the priority diagnoses, which is risk for ineffective cerebral tissue perfusion, ineffective airway clearance, and risk for injury. So know that those are pretty much the takeaway of this chapter. Just know what the interventions are, know what the PT and PTT lab values are and what they mean. What are you going to do as a nurse when you recognize symptoms? What is the emergent care? What is the post-care of people with stroke? And your role as a nurse while taking care of such patients.